All right, class, you've made it through the top 100, but pharmacology never stops there. Here's a bonus set of medications you'll see in real practice and on advanced exams. These are the ones students sometimes forget because they're not always highlighted, but they show up on the floor all the time. Cardiovascular hydrochlorothiazide, or HCTZ. This is your thiazide diuretic. It's milder than loop diuretics, but still wastes potassium. That means we're watching electrolytes and watching for dehydration. If your patient says they're dizzy when they stand up, check that pressure and check that potassium. Atenolol. This is a beta blocker, just like metoprolol, but a little more selective for the heart. Still, hold if the heart rate is under 60 or the systolic blood pressure is under 100. Remember, beta blockers can also mask the signs of hypoglycemia, so a diabetic might not get that shaky, sweaty feeling. Their first sign of low sugar could be confusion or a seizure. Anticoagulants, DOACs, apixaban, rivaroxaban. These are the newer anticoagulants, direct oral anticoagulants. The beauty is no routine lab monitoring like warfarin. The risk is still bleeding, so we keep an eye on bruising, blood in urine, or black stools. Patients love them because there's no weekly INR draw, but nurses need to know. There's no easy antidote for some of them. If they bleed, it can get serious fast. Endocrine Fludrocortisone. This is a mineralocorticoid. Think of it as replacing aldosterone for patients with Addison's disease. It helps hold on to sodium in water, which boosts blood pressure. But the trade-off? It can cause high blood pressure or throw off electrolytes, so monitor both closely. Neuro and Psych. Atypical antipsychotics. Olanzapine, risperidone. These are newer generation antipsychotics. They don't cause as many tremors and stiffness as haloperidol, but they do cause metabolic issues. Watch for weight gain, diabetes, and high cholesterol. If you've got a young patient on these, you need to keep an eye out for long-term health risks. Infectious disease and GI metronidazole. This is a workhorse antibiotic, especially for gut infections. The golden rule, no alcohol. Even a little wine will make them violently ill with nausea, vomiting, and flushing. That's the disulfiram effect. It can also make urine turn dark, which is harmless but alarming if the patient wasn't warned. Mesalamine, or 5-ASA. This is for ulcerative colitis. It quiets down inflammation in the bowel. The risk is kidney problems or blood dyscrasias, which means abnormal blood counts. That's why we monitor kidney function and CBCs. H2 blockers, ranitidine, famotidine. These reduce stomach acid. We usually give them at bedtime so the stomach isn't pouring out acid overnight. In patients with kidney disease, dose adjustments are needed because they're cleared through the kidneys. Loperamide. This is Imodium, slows diarrhea by acting like an opioid in the gut. But here's the warning. Don't use it if the diarrhea is from infection. If you stop the diarrhea while bacteria are still inside, you just keep the infection trapped. That's why we always check the cause. Genitourinary and reproductive oxybutynin, used for overactive bladder. It relaxes the bladder muscle but comes with anticholinergic side effects. Dry mouth, constipation, blurred vision. Think can't see, can't pee, can't spit, can't, you know the rest. Tamsulosin, an alpha blocker for enlarged prostate. It relaxes the bladder neck so urine flows easier. Side effect? Orthostatic hypotension. Patients can pass out when standing up too fast. Teach them to take it at bedtime. Finasteride, also for prostate enlargement and even hair loss. Here's the kicker. It's teratogenic. Pregnant women should never handle crushed tablets because it can affect male fetal development. Sildenafil, or Viagra, famous one. For erectile dysfunction, the #1 rule, never take it with nitroglycerin. Both drop blood pressure, and together they can bottom a patient out. Priapism, an erection lasting longer than 4 hours, is an emergency. Teach patients. If that happens, head to the ER. Pain and sedation ketorolac. This is a powerful NSAID used short-term for pain. Never use it for more than 5 days. Too hard on the kidneys and stomach. And like other NSAIDs, avoid in pregnancy past 30 weeks. Tramadol, kind of a weak opioid, but don't be fooled. It can cause seizures and serotonin syndrome if combined with antidepressants. Always screen for SSRIs and MAOIs before giving. Ketamine, an anesthetic that can cause dissociation. Patients feel like they're outside their body. It preserves airway reflexes, which is nice, but emergence reactions, vivid dreams or hallucinations are common. Monitor closely during recovery. Propofol, short-acting IV anesthetic. The big risks. airway suppression, infection if the vial isn't handled sterile, and high lipids because it's fat-based. Always monitor airway and follow strict sterile technique. Midazolam, or Versed, a benzodiazepine used for sedation. Antidote is flumazenil. Watch blood pressure and respirations because it can cause significant depression. Methadone, used for opioid withdrawal and chronic pain. The risks? It can prolong the QT interval, so watch the heart monitor, and it depresses respirations. Careful titration is key. Oncology and immunology, cyclophosphamide. Chemo agent, classic side effect, hemorrhagic cystitis, bleeding in the bladder. That's why we give it with Mesna and plenty of fluids to protect the bladder. Doxorubicin, nicknamed the Red Devil. It's red in color and damages the heart. Always check an echocardiogram before and during therapy. Rivaroxaban can help protect the heart. Tamoxifen, used for breast cancer. Works as an estrogen blocker, but here's the risk. It increases the chance of endometrial cancer and blood clots. Teach patients to report abnormal bleeding or leg swelling. Interferon alpha, used for certain cancers and viral infections. Common side effect? Flu-like symptoms, fever, chills, fatigue. It can wear patients down, so support is important. Emergency and critical care epinephrine. This is your anaphylaxis and cardiac arrest drug. For allergy emergencies, give it IM in the thigh. It opens the airway, raises blood pressure, and speeds up the heart. Always teach patients with EpiPens how to use them. And to call 911 right after. Norepinephrine, or Levofed. Vasopressor used in shock to raise blood pressure. The danger is extravasation. If it leaks into tissue, it can cause necrosis. That's why we monitor the IV site closely. Antidote for extravasation is phentolamine. Dopamine, dose-dependent drug. At low doses, it improves kidney perfusion. At medium doses, it boosts heart contractility. At high doses, it clamps down vessels like norepinephrine. Always on a pump, always with close monitoring. Dobutamine, another heart helper, increases cardiac output without squeezing blood vessels. Great for heart failure. Monitor ECG and blood pressure carefully. Adenosine, for supraventricular tachycardia. Here's the dramatic part. It causes a few seconds of asystole before the rhythm resets. Push it fast, followed by a flush, and warn the patient, you may feel weird, but it will pass. Amiodarone, antiarrhythmic, very effective, but comes with a laundry list of toxicities, lung fibrosis, liver injury, thyroid issues. Before starting, patients need a chest x-ray, liver function tests, and pulmonary function tests. Atropine, used for symptomatic bradycardia. It blocks the vagus nerve and speeds the heart. Watch the heart rate, and remember, contraindicated in glaucoma because it increases eye pressure. And that wraps up our bonus list. Over 30 extra medications that expand on the NCLEX top 100. These are the ones you'll see in critical care, oncology, or real-world practice. Remember, it's not about memorizing every side effect. It's about understanding the why. Why you check the kidneys, why you check the CBC, why a drug interacts with another. When you can explain that, you're not just passing the NCLEX, you're practicing safely as a nurse.